Good morning and welcome from all around the world to Structural Heart Live Cases broadcasting from the Cardiac Catheterization Laboratories of the Mount Sinai Hospital in New York City. I'm George Dangas and I will be the moderator for the day. The video broadcast will be available at this website as usual a few hours from the end of the case, and the last webcast of Structural Heart Live Cases that was on September 11, as well as all the previous Structural Heart webcasts are available at the website you're viewing, www.ccclivecases.org. As usual also, we'd love to hear your comments or maybe your questions, and I'd like to take your questions and transmit them to the operating team online as we get it, again, through the website that you are viewing. So we have a great case planned again. We apologize for a few minutes of delay, and we just go straight to the cath lab to meet Dr. Sharma, the rest of the operating team, Dr. Kinney, Dr. Kovacic, and Dr. Gilbert Tang.
Good morning and welcome to our Structural Heart live webcast audience from Mount Sinai, and thanks. And we have a little different setup today, but very interesting case, and we are ready to start with always we try to bring some important point in case of presentations of a particular case. Most of the faculty, those who have attended our earlier webcast, are aware of. Myself, Dr. Sapien Sharma, on the left side is Dr. Anpurna Kini, then Dr. Gilbert Tang, my left side, Dr. Jason Kovacic on the right side, and then we have Dr. Stam Larakis is our echo cardiographer who has moved actually now from Atlanta here, and he'll be giving the commentary on the echo. Then we
if he can move next to Dr. Tang, we can also see him in the
we want to see him also, yes. And then fellow Dr. Muhammad Khan, and then we have our anesthesia with Dr. Brent, and so we are ready to start with this particular case. While we are going to do a few things, if we can start our slide presentation, which again things are changing. We ourselves are trying to get into accustomed. Today's webcast is supported largely by Edward Life Sciences with the Terumo Medical. So these are our disclosures. This is a 96-year-old male who presented with severe dyspnea. It's the episode number 26. Has for last few months heart failure, and these are the other comorbid conditions, and he had AFib on warfarin. The labs are there, creatinine is good, which is what we always worry about, and INR is less than 1.8. AFib, patient did have a cath a few weeks ago, which was non-obstructive CAD, and echo shows near normal LV function or mild diffuse with the severe low flow, low gradient aortic stenosis with SVI of 27 ml per meter square, but patient very symptomatic, and so now we actually if we put it together, this is the echo. So Stam, you have to comment on it, and then you'll have the live echo later.
Yes,
we cannot hear you, Stam, very well. Speak up.
Stam louder.
The ejection fraction is
cannot hear Stam very well. Please bump up the volume.
the ejection fraction is about 50%. As you can see, severe aortic stenosis. The gradient is about 16 millimeters mercury.
Do you see what he's doing? As people are talking, they're showing that in the side.
So the peak velocity seems to be 2.7. I'm just repeating a little bit to enhance the experience for the audience. The mean gradient a bit lower, about 20, and the ejection fraction is, as I heard, around 45 to 50%.
Yeah, and then this is the basically classical of the low flow, although now, I mean, it was a normal ejection fraction before. It's now, but clearly this was about a month ago. So if we take it back, this will fit into that criteria, SVI of stroke volume index of 27, less than 35.
Less than 35, yes. Let's talk about this parameter, Dr. Sharma. The stroke volume index less than 35 is what's used in by specialty echocardiographer in order to qualify this type of phenomenon, the low gradient, low flow AS. So it's very important for us to learn about it.
Right, absolutely. This one will be paradoxical AS because of EF more than 50%. So low flow, low gradient, paradoxical aortic stenosis is the case we are dealing with today. Very symptomatic patient at this age, at 96, is still very active, goes to work, and clearly having these symptoms very much, and that led to this whole workup. We did a TE, we did a CAT scan, and all those really culminated to this particular procedure now. That patient was appropriate because of symptoms and low flow, low gradient, paradoxical AS. So Jason, you talk about CTA?
Sure. Good morning, everybody. So CTA assessment of this patient gave us what's actually quite a large annular perimeter and annular area there. You can see the max and mean dimensions 33 by 27 gives us a mean of 30.5. As you'll know, the Edward Sapien system, the largest is a 29 valve. So we're actually going to be placing a 29 valve into 30 millimeter mean annulus. You can see the area there is 713 millimeters squared. The normal upper area for the 29 is about 680, 690. So we're actually going to be putting the valve into this annulus that's slightly larger than the recommended. You can see there, though, significant calcification. If you look at that upper image there on the right, with that calcification extending from about 3 p.m. down to about 7 p.m., which of note for us is in the short plane of this annulus. So we do need to be careful that we don't get too aggressive, because we'll be stretching that calcium you see there from about 3 p.m. round to 7 p.m.
We'll get to talk about the oversizing a little bit later as well, I suppose, Jason, but let's a little bit give us an input that sometimes we use by the CTA in this low gradient, low flow aortic stenosis. Quantitatively, they can quantify the valve as well, and usually they find less than 1 by the CTA. That is yet another way to confirm, so to speak, that critical AS exists in this case.
Sure. So the assessment of aortic severity by calcification is done with the angstrom score, and it's done in these situations of paradoxical low flow, low gradient, and so on, when we're really, working hard to try and figure things out. So the cutoffs are, for a male, 1200 to 1400 and above is considered to be significant AS, and for a female, it's 2000 and above in angstrom units. Definitely, that's obviously not done at the annular level. That's done up through the whole valve and through the leaflet tips. But that is definitely one metric that can be used to make an assessment of aortic stenosis when you get into these situations of, reduced ejection fraction, low flow, low gradient. So let's just move through and complete this. The annular angle you can see there on the bottom right is good. Moving through all our measurements, sinus of Valsalva is very generous. We're not concerned by this at all. STJ height, STJ size, and so on, all within range for a 29 millimeter valve. And you can see the coronary heights there are generous as well. So from these perspectives, no concerns. You can see here in terms of access, significant tortuosity, particularly on the left with that very acute bend up there in the common iliac, but also on the right side. And we've accessed the right side, which we'll show you the pictures of in a moment. Next. And here, just planning for sentinel, you can see us looking at the innominate artery and the left common carotid artery. They appear favorable. They're not too tortuous for a sentinel. So that'll be our plan to place a sentinel for you today to protect this man's cerebrum. Next slide. You can see here by all measurements, this patient does come into the 29 millimeter Sapien-3 valve size, although with the caveat that we're actually going above the normal recommended mean annular dimensions up to about 30 here, but it's not outside the range of what's commonly done in routine practice. Next slide.
So basically put this together. This is the case with the high STS risk of 12 and low flow, low gradient, paradoxical severe AS, evaluated by heart team, and of course extreme risk for SAVR.
Yeah, definitely.
Now question is, what is the absolute cutoff? Where would you not use a 29 millimeter Sapien in terms of the parameter?
Yeah, I think that's a great question, and that's dependent on the amount of calcification. So if we have a lot of calcification, we're able to anchor things at a larger annular size, but if there's minimal calcification, we get far more concerned with going up to these larger annular sizes. Okay. So it is an individualized decision.
We are in about 720, let's say, 710 to 720 range, and this valve nominal goes around to 660 or so. So exactly. we essentially need to somewhat overexpand it, and it can be overexpanded without significant central aortic regurgitation if you add up to 3 or 4 cc. So definitely 2 cc's is well within the range to be overstretched in some ways.
Yeah, and I think we need to be careful. This gentleman is 96 years old. We don't want to be too aggressive in someone so elderly and obviously frail.
And that's actually comes back to Gilbert. We saw the calcium in this case, and now we are putting additional the dye to expand our Sapien valve. About 2 or 3 cc's or 4 cc's what we have. Is it concerning for you? What do you think?
Yeah, certainly it depends on the 96-year-old, the tissue quality is certainly not like an 86-year-old, so we have to be careful as what Jason said. But I think what we will do is that by adding some volume, we really try to avoid balloon post-dilatation, because we know that balloon post-dilatation can also risk annular injury as well. So by preemptively adding some volume on an extremely large annuli, I think we probably is what we would prefer, at least in our program. And we can talk about the paper that we published before recently on a multi-center study talking to these types of patients.
Well, definitely in these frail patients, you wanna do everything you can to avoid the post-dilation. And clearly, if you implant a valve that is not well sized up front, you also risk for embolization in between. You don't want to do that. So, figuring out a safe and effective over dilation volume, if you want, is a good one. And I wouldn't go to maximum very reasonably, as you said, in a 96-year-old, but the plus 2 cc seems to me a medium range for the 29 millimeter valve.
Yeah.
So now we are ready for the Sentinel.
No, we are taking over the Sentinel. I just want Gilbert, can you just discuss the multi-center data that we have that we just submitted?
Yeah, we might actually talk about that in the discussion session. But so we had a multi-center, about 16 centers compiling about 70 plus patients on these patients with extremely large annuli, and actually the range that we treated up to 850 or 800 millimeters square on the extremely large annuli with the 29 Sapien-3 with different degree of balloon expansion. So, but this is something that we will talk about in discussion section, is that it can certainly some trade-offs. So if you have a larger annuli and your LVOT is larger, you do risk a little bit higher mild paraviral leak or central AI. But at least the data in the JACC intervention paper show very favorable outcomes in terms of low mortality rate, low pacemaker rate, and a very acceptable paraviral leak consistent with the literature published in the Sapien-3. So we feel pretty confident that this case with the annulus of just over 700 with the reasonable amount of leaf-like calcification should be fine.
Okay, so now show, go on fluoro now, please. Okay, so no, show the arch angiogram first.
You want to show the arch angiogram?
Definitely, before we go.
They can show the, this is the DSA of the arch angiogram. You see that? You will see the common, and then you can see the left carotid. Can you just stop there, right there?
Yeah, it's a tough.
Yeah, this is perfect. Yeah, it is perfect. We can see it very clearly here. There is some distance between the two. I know sometimes the take off the left carotid can be a little bit tricky if it's bovine, or sometimes if it's very close to the innominate. Over here it is well separated.
So now I'm going to release the first one, the number 1. Good. And then you tighten. So it's anchored in the right place. I'm pulling it back.
Let's mag up one. So
I think you're okay there. Pull the, pull the wire back more.
Yeah.
You're in the, yes.
I think you have to open a bit.
Okay, yeah.
That's the arch.
Arch. Good. Okay.
Mag out.
I'll bring it closer. Okay.
Good.
Lock it.
Check. Put a catheter there. Yeah, we're below that. It's above the catheter.
Advance. Hold the wire.
Yep, I have the wire.
I'm going to advance the. Okay, good. And then you lock it. Number 3.
Good.
Okay, we're good to go. Give me some blue towels. Okay, we deployed the Sentinel.
Say the ACT.
Where's the second one?
No? ACT is 3. No, second one is out.
Yeah. Okay.
Yeah. You mean the
You can
blue
see
towels?
it there,
Yes,
yeah,
alright.
very,
Yes.
they did very so quickly. So it takes around what is showed in the trials 10 minutes. Now it's about 4 to 5 minutes. And now, fortunately, there is also a reimbursement now for this procedure has started as of last month. So it will be very, very helpful knowing that the data have shown that where you can deploy the sentinel, which may be limitation because of various excess, the radial, the angulation of the innominate, and so that definitely decrease your major stroke by half and decrease the small the MRI lesions by 60-70%, and the few studies even have shown the mortality benefit of the using the device. So we actually have made that as a quality indicator that every case it has to be written that if you are not using sentinel, the reason for not using sentinel. So that's a very important point. Okay, now we are ready to for.
No, we're going to change to AR2.
Put these up.
So you can see here, this is the aortogram of the aortic root. It's a very large aortic root. You can also see on the right side, right underneath the left main, there is some LVOT calcification there. So this is something that we do routinely to get the implant angle, but also to assess the degree of leaflet calcification or any kind of high-risk features, such as the risk of coronary obstruction in this kind of aortogram. This is a very important step in the process.
And this patient is being done a kind of a little modified general versus local anesthesia. And I'll talk in my didactic discussion the recent TAVR trial, which compared balloon expandable with the self-expanding and general versus local anesthesia. So local basically is our MAC, moderate sedation. Although this case was given a little extra sedation, but definitely not intubated.
So we have AR2 or AR1?
AL1.
AL1, yeah, because of the large, anytime when you think that you're going to use a 29 or 34, 29 Sapien or 34, the Evolute, we go with the AL. Otherwise, AR2 is our the workhorse.
Yeah. Interestingly, I have to say the many labs that have just different defaults. I just heard it. I just want to say because it's quite different. John Webast always starts with AL2. And on the other hand, I don't think we've ever used AL2 in Mount Sinai. And I think, that's an interesting variation there.
No, not only that, I'll give you the history behind it. So back in 2010, before the core valve trial started, when we had the investigator meeting, there was the protocol was written that AL2 will be used.
Yep.
I said, absolutely not. I was the one, I said, no. We have published the paper. The best is your AR2 with a stiff shaft angle Terumo. So actually, if you go back to the original paper of early 2010, because knowing that we did the last case, first case in December 18th, 2010, the investigator had that AL2 as the
that's so damp. Don't
start. Now, what is the?
No, I understand. Somehow AL2 works in their lab and AR2 works here.
Yeah.
And there's no question that both are true. It's just interesting that there's some variability.
In routine, I can tell you in many cases in the small aorta, AL2 will be big. AL2 will be big. Why there is no pressure? There should be one pressure.
We have left the stiff wire.
Can we adjust, please, the screen so we can see the hemodynamics in one screen? We don't need the two operator screens.
We don't have pressure down here at the moment, so just keep us posted.
Map is 70 something.
Yeah, I think what they should do is maybe one hemodynamic and one very good.
Yeah, excellent. That's what we do. I'm helping out.
And showing the hand.
Yeah.
Dr. Keeney always wanted to see the hand.
Exactly. Yeah, that's what exactly. We already seen the faces of the operators and all that. This is a perfect setup. And most importantly now, let's focus on the technique that you see that we always replace the straight shaft glide wire with the pigtail. And then the next wire goes in. We don't go with over the Amplatz catheter with a stiff wire in this laboratory.
No, 22.
22 is fine.
Okay,
and you can see that how easy this makes the placement of the stiff wire at the apex of the heart, and then allows that to form a very nice curve.
Let's see what the pressure is.
We'll do the BAV.
Huh?
Right, BAV.
Because large valve,
20.
it will stick there.
Yeah.
Well, of course,
I
in my
think
mind, I know
22.
there's a lot of discussion
22.
regarding
Let's not
doing or not
try to
doing
do
pre-dilation
This one,
in
huh?
a valve like
Should we
this
do it,
one that you
BAV
want to
on
22,
oversize it
22,
and
yeah.
you want to avoid the post-dilation. I'm not sure how you could
Give us a
avoid
22
also
millimeter
the
valve.
pre-dilation.
Balloon.
Yeah, so it depends on the degree of calcification, how much baseline aortic insufficiency there is. So a lot of centers now starting to skip the pre-BAV, but we certainly are selective. In our cases, certainly in bicuspid aortic valve, we still do routinely pre-BAV. Heavy calcification, we also like to do that, just so that when we cross the valve, we don't cause potential hemodynamic instability. Jason, you have any thoughts?
No, I agree, and it's definitely an individualized decision. With the annulus here that's actually larger than the recommended for the valve, we obviously don't want to be too aggressive, because if we stretch things too much at this stage, it makes it more challenging for us to anchor when we deploy the valve. So that's why we could easily take a larger balloon here, but this is just a 22 to sort of go compromise between not being too aggressive,
Okay.
enabling
Go
us to
just
get
to
the
the
one-
anchor.
120 only,
120
Great.
pacer.
We're ready
So we have a
now.
22
It's
balloon
right
across.
across.
Yeah.
And we're going to
120.
do rapid pacing, and Dr. King will inflate.
And so you can
How
see
do I know
the
it's...
waist,
Oh, Dr.
the
Sharma is
wasting of the
inflating.
balloon is the wasting of the balloon is very important to see. So clearly the
Yeah,
valve
yeah.
is
Hold the
calcified.
sheet.
Off pacing.
Yeah.
Stop pacing.
The valve is clearly calcified, because if it's not, then you would have seen the balloon not having to have a waste during the inflation. And that's something that we also check in terms of risk of coronary obstruction or kind of the sizing. The,
Okay, we need a little push
sizing.
of the blood pressure.
No,
Well,
no,
I mean,
that's the
obviously,
wrong
in other
blood pressure.
cases,
It's
here
from the
there's
sheet.
no question
You
that
okay,
we're
Ben? Your
blood pressure is
undersized and
okay,
that
right?
the valve is calcified. So, clearly we need a pre-dilation in
So
order to be able to
before you go in,
seamlessly
always check for the
put the
orientation of the
valve
valve.
in and allow
You see
the
your
expansion.
skirt facing down towards the LV
Can we
cavity.
zoom to that? I don't think we can
you
see
zoom in?
that. We can hear you saying that, but wait for a moment and I'll tell you when to do the explanation again. Yeah, let's just do the explanation again, Anu.
Okay. No, lights down.
No, but you to see
It's
that.
good. We can see better. Don't worry about it.
Okay,
We can
okay.
see from
Yeah.
here.
No, just see the orientation. You see
Yeah.
your skirt. Skirt
Uh-huh.
has to be facing
Yes.
down, so it will be going into the patient first.
Okay.
Yeah, the white
So
portion.
once it's going in the body, right now, you can keep
That
showing
is always
our,
useful to
finger
check. We
movements.
can unzoom now. We don't need to be so zoomed.
No, we'll show all the movements of the valve.
Yeah. Okay, you got wire, Jason, or not yet? You
Good.
have wire? Okay.
Okay.
So this is a 29 Sapien-3. So when you insert the sheath, it can have a little bit of resistance. So you just kind of have gentle forward pressure, and you'll eventually be able to open the E sheath, which is 14 French ID. 16 French ID to extrude the
good.
valve here.
Seems
Okay,
like
so there
went
we
very
go.
well.
Yeah.
Perfect. Okay, good.
Okay.
So what's the
when you're
next step
there-
over here now? We have to go to
So you will
APLL
see-
cranial and
No,
do
not
what?
yet, not yet. First, we'll do the movements here.
Yeah.
Now, since this is 29 and you want to see the pressure, remember this 29 does not come with the pressure.
Can we zoom
gauge.
in on can we
So-
zoom in on this, please?
We have this three-way stop.
Move
off.
the camera,
This is-
please.
zoom
One second.
on
Hold on the explanations, please. Move the camera,
let's
please.
make sure the camera.
Show these
shows-
gauges.
Yeah.
No, move the camera down to the table where the deflators
Yeah.
is. Great.
Yeah,
Zoom
right here.
now.
Yeah.
Can we zoom then, please? Yes.
Give me blue towels.
Yeah.
Very good.
Right
Good.
there. Good.
Okay, let's
Okay.
start the explanation now.
Okay, the explanation right here. Normally, it comes with this indeflator, 29,
We
but
see
there's
that.
no pressure gauge connected. So especially in a calcific valve like this, you do not want to go more than 7. Yeah, that's what
7
normally we are looking
atmospheres,
for.
you mean?
7 atmospheres, yeah. So if you see, this is a three-way, which I think most people are doing, but we are also doing. So you're connecting. So when I'm going up, inflating the valve, you will see the pressure here. Okay? So you have to
Okay,
be
let's see
careful.
that.
We have
Let
to be
someone
careful
please
which one you
hold the.
inflate.
One second. Someone needs to
Hold
please hold this. So hold the deflator in such a way that the camera can always see the 7.
There,
Okay,
George.
great.
That's right.
And
Okay,
during
this is
the
the
inflation.
indeflator, non-usable. Look at this. We have put a
Yeah.
tegadum, which means you are not using this
Yeah, this is
indeflator to
only for
inflate.
pressure.
This is just
Yeah,
a
okay,
pressure
great.
monitor,
Okay, great. Yeah,
And
we'd
this is
like
the
to see how that
indeflator.
works.
which I'll be using to inflate the valve.
Good.
Is that clear?
Yes.
Okay. Now we are going up. Yes, we'll do the movements where we are going to bring
Go
the
back on floor
balloon
now.
inside. So what you do, keep showing.
The fluoro image. Yeah, good.
I'll show it. But
Yeah.
are they showing me?
Yeah,
Yeah.
showing. That
No,
right
no,
there.
they're not. Ain't
Yeah,
Showing both.
Yeah, both. Yeah.
Yeah.
No,
No,
they
we're
won't
all
see.
set here. Don't worry. We'll
Okay, good.
collect the cameras. The cameras are good. The eye is in AP position, a little bit cranial, seven cranial, and well, it's a little bit over the guide. That would have been a little bit better if it's not over the guide, but anyhow, the balloon is coming back.
Balloon is back, lines in position, and now the smaller wheel is done. Now we are going to use the larger one to rotate.
And let's try to go towards the LAO and a little bit of the implantation view.
And as you're going across the arch,
Nothing can clean this.
you just flex more.
You got to watch
be careful with the
watch all the other
sentinel.
equipment there.
Sentinel. Yes, we are across. I'm fully flexed. We're
Across
getting
the
into
arch,
LV.
and now getting
I
in the
will
LV.
undo some of the flex.
There's a mag in.
Yeah.
Undo some of the flex.
So far, so good. I think you're
Let's go to the angle.
Yeah, I got it.
all right. Can you cross? You're a little bit out now. You were
Yeah,
kind
bit
of in and out.
Yeah.
Okay.
That's okay.
Expose the balloon.
So now we just
Yeah, you cross.
Okay. Now let's adjust the pigtail.
I think probably
doesn't
take the
bother.
hypotube
Good,
just
right?
a little
Yeah.
bit back.
yeah.
I think it's the center marker is good.
So the central marker, we try to position the bottom of the central marker just above the annulus. Now, in the extremely large annuli, people might say, well, let's put it more in ventricular. But in our paper, we show that that's not actually beneficial. We just put it where it's supposed to be, and then depending on the degree of calcification, the valve is going to foreshorten from the ventricle in different degrees. So in this case, it's pretty calcified valve. We don't think it will foreshorten so much that we'll risk to have 100% aortic deployment. But certainly, we'll check right now using the aortogram. Pressure's
Okay, let's show the inflation now. Can we have the camera back here?
But bring the pigtail to the.
That's all
Yeah.
we can do.
Yeah, yeah.
SS.
Okay, good.
Yeah,
Yeah.
Good.
So, yeah.
That's good.
It's actually
Okay.
good.
Yeah.
I'm just undoing it. Okay, we have to go pace 180.
This one, try to keep less pace because RV is a little down.
Okay.
Maybe 160. 160 will be good enough.
Look at the blood
That's
pressure.
fine.
It's not
Yeah,
going
very good. Blood pressure is low.
Yep.
Okay, let's inject.
Inject.
Good. Okay.
Okay, stop.
Position
Stop
looks
pacing.
great, no?
Yeah, looks great. Yeah, I agree.
Okay, we'll be going up now.
Yeah.
Okay, good. Pace 160.
160 only.
Pressure is what's
Nope.
the PVC?
Right?
So one-
Okay, going up.
Okay, sustained.
Keep going, keep going. Okay, now
Definitely.
tell me. I'm just 7. You can show the pressure gauge.
Yeah, this seat. Yep, 7.
Yeah.
Good.
Yeah, there's some parallax there.
Okay,
Dr.
stop.
Tang will move the camera, so there's no
Leave
parallax.
it at 70.
No.
That's just
1
what-
second.
Good.
Yeah, resuscitate, please.
Good.
Yeah, very good response.
Nice.
Yes.
Yeah.
Okay, wait, pigtail.
The pigtail.
Yeah.
You have to put a wire
Pigtail
into the
is
Okay,
pigtail.
pace
Give
at
the wire.
70, please.
Pigtail is stuck here.
Put a wire in the
Give me
pigtail.
Super stiff.
So
You
the
need
patient has
airport, super stiff.
baseline right bundle AFib. So we'll see what's going on with the heart rhythm.
All right, for our purposes, pacing at 70 is a very smart thing after the deployment. That's very good. So we control the situation and we have reliable hemodynamics. This is not unusual to use it, even if the patient doesn't have this particular problem of the conduction. So let's let's try to understand what's happening. Off parallax, the valve seems to be very stable, very well
The
expanded.
J wires on the front.
And hemodynamics are okay right now.
Patient is very stable. Blood pressure was about 100, and the heart rate is about 70 paced.
You want echo?
Take this.
Let's do the.
Pressure is 120 even. Yeah.
You want to do the echo quickly?
Yeah,
No,
echo.
we do aortogram first.
Aerogram first.
Aerogram,
Okay.
aerogram, yeah.
We have the wire across.
Okay,
Yeah.
so let's mag
That's
in
okay.
and then we'll
This is still okay.
look at take the parallax out.
The reason SS echo, if there is anything, we can go back and inflate.
Yeah, but we'll decide based on this.
No.
Okay.
Yeah. All angiogram.
Okay. Okay, take the.
Yeah, we'd
parallax
like to
out.
see some angiogram here. We haven't seen much angiogram, and our viewers
Okay.
are asking questions about angiogram.
Let's
How
put the
come not
We are
much?
doing it.
We're
fluoro?
working on the
Okay,
Yeah,
we're
doing
doing
it
it
now.
now.
We're working on parallax, George.
Yeah, yeah.
Good. Parallax
First
is
of
good.
all, Dr. Tang
Nice.
needs to fix the parallax.
Yeah, done.
Good.
Okay, good.
Done. Keep holding. Okay. Inject. Oof.
Yeah.
All right, echo
There's
now.
some-
Looks like more central.
I think it's central.
Yeah.
Good.
Okay,
So
we
you
can,
can see here- you
we
can
can
see here-
reassess with a pigtail
Yeah.
in
On
the
the
ventricle.
aortogram. Yeah. On the
Add 2
aortogram.
more
Look at
cc's
this.
in preparation.
So despite a very large annuli and the degree of calcification, and we put the bottom as the balloon marker just above the annulus, it was not very aortic position. So that's why, in our paper we show that you do not need to do that for this valve. even with a large annuli.
Okay, well, let's see how the echo goes. You're going to replace?
Show the echo.
Yeah.
Nice.
Let's decide that.
Pressure. Can you flush the
Let's
pressure?
take a look at the color now in the echo.
Great position.
Keep talking, Sam.
What about the AI?
No AI.
There's a bunch
Oi.
of air, isn't
Yeah,
there?
that was central.
Trivial AI, a little trivial
yeah.
paravalvular
Okay, go to the
and,
short axis.
and a mild
Actual-
central.
Actually, nothing by
Five
echo.
different
This,
impressions.
Nice. Beautiful.
Nothing much.
This way.
nothing much.
Trivial.
No pericardial effusion.
Trivial.
Good
And
function.
even
Trivial.
the position is so good.
What volume do you want?
Good.
Trivial paravalvular,
So let's
trivial
take this one
central.
out, put a pigtail.
Actually, not even trivial.
Not even trivial.
Not
Well,
even
was
a
trivial.
single
That was
RBC.
mild by cath, so I was to give a little trivial by echo.
I know.
Yeah.
I would call it a trivial. Yes. Okay. Let's get the pigtail ready.
Let's
We're
get the
going to-
pigtail
let's-
to
we are not
understand
adding
better.
new one.
Access.
I
We don't
need
need
short
it.
axis.
Short access, please.
Certainly nothing that we
And then
could
the
post
apical
dilate.
fire chamber.
The utility of this echo again is not to quantify definitively the AI, is just to make us decide are we going to be pushed towards post-dilating, which we're going to do anyhow, or to push us for post-dilating in case of a major AI. We don't seem to have that.
Yeah.
If
This
we're
is
that is the
proceeding
point,
with the
because
removal
we-
of the system.
5-chamber view. No.
Because we added 2
no
cc's
PVL.
earlier, and we were ready with the additional 2 in case we need it.
Good.
Yeah. Not
No
good,
effusion.
No effusion. Nothing.
Okay.
Let's take this
We are
out, put a
coming out
pigtail
and then
inside.
we put a
So
pigtail.
therefore, the
Pigtail.
decision is made. There is a trivial to a 1
Let me
plus or
make it.
minimal AI.
One sec.
We are going to put a
Go.
pigtail, do the hemodynamics, and take the pigtail out
balloon
so
is
that
still
no
not fully
central
deflated yet.
AI, and no region for the central AI, and then do the aortogram.
Okay, sounds
Should
good.
be now.
Sounds good. And by the way, the pigtail might have been just a little bit too close to the valve when we're doing this AI,
Earlier,
this
yes.
aortogram.
No.
So maybe it kind of helped out a little bit the central AI. We see now in the repeat ones.
Okay, give us the pigtail again.
You should show how to remove the sentinel.
Now diastolic pressure is about 50.
No,
We have a stiff wire across.
There's still the wire there across.
Okay, you have wire?
Yep.
Okay, good. Okay, good.
All right, very good.
Let's flush both of them. So good tracing.
And yeah, again, I have to say this is a borderline case, even in the definition of low flow, low gradient AF. The ejection fraction is 50%, so
Yeah.
it's not less than 50, but it's not normal either. So it's probably on the way to become lower than that due to the significant AS, and I think this has been halted by the
No gradient
procedure on
here?
the way.
you see that?
Yeah, close the blue.
Yeah.
Close the red. So
Yeah,
confusion.
the red
No
has
red.
dye, so
Yeah.
we're gonna do the hemodynamics without, and it seems to be 140 over
No,
maybe
no, no.
22
Close the red.
in the LV.
So that
Close the red. Only blue
Can
and
you close the
yellow.
red and have the blue, please? Let's see if we can achieve that in the hemodynamics view.
Now why there is a gradient? You want to flush them?
it may
Can
be
you
because of
open
the
No, show
open
the
both
red.
and
Re-zero
open
the
and
red,
zero both,
please.
please?
pigtail up the left may be slightly kinked going
Yeah,
through
yeah.
that common iliac. It's a very, I think it's
No,
slightly
you
kinked.
need to re-zero, right? It's higher. Yeah, re-zero everything.
Yeah, open everything. 200 scale, 0-3 channels.
I suspect it's
Zero the red. Flush. Open to the patient.
Open
George, yeah.
Close
open the
everywhere
blue
else.
channel also.
It's
All right,
very
let's-
important to re-zero all these. Yeah.
Zero all of those because they
Beautiful.
yeah. All right, let's see now how it goes.
Yeah, it's kinked.
Get rid of the
Okay.
get of the red
What
first
is
of
okay,
all.
Don't
take the
worry
red
about the
out.
red. Why are we worried about the red? Why
Okay,
not
okay,
with
we are
blue
done.
and yellow on
Coming
The
the
red has
Coming
dye, we said, so don't worry about it. Let's open the
Keep
blue.
the red closed. Just show there is a pressure trace. No. Now we have to flush.
Oh, yeah, too much.
Good. So this is what we need. Yep.
Exactly.
Good. So there's about
Looks
5
like
millimeter
I
gradient.
can promise you there is a drift in the blue transducer. That's what happened
100%.
because over time the gradient increases. There is something something loose in the blue transducer. Anyhow,
But you needed to.
there is something near the table in the connection,
Right.
not where
You need
you
a
are
ruler.
working
Pull
Anu
back and do with this
in
one.
the
No,
something
just this
there.
one. Go back if you can advance.
Cannot.
We can do it. We'll do this one. We'll do this one.
No. Which one is the red?
This one is a red.
Okay, and where is the blue?
This is the
You
blue.
can attach the red to where the blue is. Just flip them because the red is filled with dye.
No. That's
But
not
the
thing.
blue
I
is low
flushed it
quality
few times.
transducer. That's
Yeah,
the
it's
problem.
basically
put
the
it-
kink in the
we can put it-
catheter.
we
Yeah.
can put it
But
in
that's
the
okay.
sheath
But we saw
can
that
still use the sheath.
less than 5 millimeter gradient,
the
which is
aortic
completely
pressure.
fine.
Anyhow, I don't
Yeah.
think much changes. We have 140 over 20 and 140 over maybe 50,
50,
in the
yeah.
LV,
Yep.
LV and AO. So, I think this is a great result. The LV pressure is completely flat. There is no indication of significant AI in the LV pressure. And these are all
Perfect.
important aspects. Jason, you want to talk about the ratio that we measure sometimes? I don't think there's a need to do that, but you can tell us about that while they're doing the
Yeah,
final
we
measure this AI
aortogram.
index, where we're
We're pulling
dividing
back.
the pressures to come up with an index. I mean, there's some caveats to that, and we tend to usually rely more on echo because I think as you've seen here, there's issues with central AI that it's much better
Keep the red
sorted out by
full.
echo.
Big
that
Taylor,
can
look higher,
differentiate-
please. Yeah.
Can differentiate central from para.
This is the red. I think
Okay, let's take a picture.
Yep.
And we see how we go.
inject.
Yep.
Yeah.
It's a
Looks very good.
raised to 1 plus, yeah. Which is okay. With this case, with the anatomy, the annulus, I would say this is an excellent, acceptable results.
Right. I mean, again, we see this trivial AI we saw by echo.
Yeah.
And, the volume appearance of the
Let's
dye
show
is a
the
different thing,
sentinel.
but
Let's
clearly
show the
there is
sentinel
some
removal.
trivial.
Yeah.
Lights
Go
down.
back,
And
lights
let's just
down.
show the
Go,
sentinel
let's
removal.
go show the sentinel coming out.
And with the cushion this valve has around, this may also by 30 days or even by day after tomorrow, when we check the regular echo on the floor, it may have disappeared.
Okay,
Dr.
first you
Kinney
bring
now.
the wire back,
Leave it out a little bit.
Yeah.
Just leave it out.
and then I'm going to
Leave a
get
little
the
bit wire.
second basket, which is number 3. Inside. Good. And then you unlock a little
Where
bit.
is the wire though?
Here, wire is down.
What do you mean?
Yes, a little bit.
It
Wire
needs
is
to
just
be a
out an
little
inch.
wire.
Yeah.
You see that? The wire is there.
Now,
Got it.
good. Unlock this one. Pull back. Now I'll get the number 1 inside.
You have to marry that to that. Now
Oh,
it'll go.
oh,
Now
good.
it'll go. Now it'll go. You have to have that married.
Yes.
Good.
Yep.
Hold it tight. Wire ahead.
Hold the sheath. Someone
Yes,
just
yes.
hold
Hold the sheath, radial sheath.
uncover this and hold the sheath.
Have the wire ahead. Okay. Coming
Just
out.
help it out. Help it out.
Yep. Okay, good.
Okay, let's flush the radial sheath.
And as
Can
you
you
saw
check
that,
for anything inside?
if you try to see that in the trial, 98% of the time they found some debris, half of them being calcium and the valve tissue and atheroma in 60-70% of cases. So it does happen, but many times you don't see it. But this is as a part of the trial. The Sentinel, we were part of the trial, and we send all those to the core lab for the microscopic. We have it, yeah. Few things, usual. Yeah.
Patient is
Okay.
pacer dependent now.
No, no.
The
we
patient
have-
has a pacemaker.
No, yeah.
No, right now?
You drop the pace. Huh? Dependent.
You want to decrease the pacemaker rate? Let's see.
It's dependent. They're saying.
Patient dependent.
Because he had a light
we can
bundle.
try.
But
We
it's
can,
AFib,
we can put the patient to 40 and see how it goes.
Yeah.
I would suggest we use a yellow channel because both the blue and the red had problems with zeroing before, so maybe more accurate pressure obtained by the yellow channel.
Yes.
Everything is coming out anyway
don't
now.
pull it, don't.
Yeah.
Yeah, but no, instead of red, if they can connect to the
Yeah.
yellow. That's what I'm saying.
Go DSA.
give some syringes.
No, syringes are there only.
Well, so far you're pacing at 40 now? What's the pacer
Yeah,
rate here?
40.
Seems to vary a little bit. There's some conduction here. Okay, we can measure some pressure somewhere, guys.
Yeah, one of them will be connecting, yes.
Yeah.
So patient
Let's go
actually
back
right
to-
now
go
is the
back to 60
pacemaker
or 70.
dependent.
Yeah, I'm
Back to
telling
60 or
you,
70,
the
okay.
pressure is more reliable with a yellow.
Yeah.
Yep, that's it.
Okay.
It's a very good pressure right now, right? And from our anesthesia team, how things are? Excellent. So we got the thumbs up from that side. So with the local anesthesia or conscious sedation.
So
Is
let's
this
talk
the-
a little bit about that. What anesthetic medication did they actually give for this case?
Benjamin,
Yeah, Yeah.
we're asking what are the medications you give?
usually.
Anesthetic.
Give you
No.
mic to him.
Fentanyl,
Yeah.
what do you give? Fentanyl?
Yeah. Propofol.
Hold on, he's going to talk. This is a Benjamin Slater, anesthesia
okay.
attending.
Hello?
Yeah,
you
go
get
ahead.
him?
We can hear you. Go ahead.
Okay. My name is Benjamin Salter with anesthesia. For this case, we used propofol. We used a Precedex infusion, intermittent boluses of a vasopressor like phenylephrine and norepi, and we ran a little bit of phenylephrine in the background.
All right. Now, if we're talking about anesthesia point of view, then you were covered with a propofol and Precedex combination.
That's it.
Absolutely, yep.
Okay, with that note, while
Great.
we are closing the groin, we are taken out the central device. See if we can go to our slide presentation again. So that takes about 10 minutes, and by the time we'll finish the closure. And
All right. Very well. Let's
we
go to
present-
slide set for
yeah.
Dr. Sharma.
Yes. So basically, always we try to point.
Slides, please.
Yeah, can we go back to the slide presentations, please? Okay, so I think knowing the one trial, the SALT TAVI made a big noise last month in the TCT. So we are going to talk about the balloon expandable, which is basically the Sapien generation versus self-expanding TAVR valve choice trials in the severe aortic stenosis. So of these two, so first report was from Pragmatic Plus initiative, which was from pooled data from Rotterdam, Milano, and Toulouse in collaboration, published back in 2013, and comparing Medtronic core valve versus Edwards Sapien. These were the earlier generation, and you see overall there was no difference in the two valve outcome in terms of safety, vascular complications, and so. So this was the first trial. Then this was at 30 days, and that at 1 year, and you can see here that moderate to severe AI was definitely lower with the Sapien valve compared to the core valve. So again, numerically, but in this study of 400 plus patient matched data, there was no difference overall in all the endpoints, slightly lower rehospitalization and heart failure in the Edwards Sapien group. Then the second study from Canada, balloon expandable versus self-expanding for severe aortic stenosis. These are the patients from Ontario from 2007 to 2013, and compare the data of their self-expanding valve compared to balloon expandable, and basically saw 1 year outcome, and then at the last follow-up. And last follow-up was around 3+ years. And you can see here, again, identical outcome between two valves. So far, what we have seen, identical outcome, except maybe a little lower pacemaker with the balloon expandable and little less rehospitalization, but otherwise identical outcome, including the vascular complication. So this is so individual other complications which are shown here. The other important thing is the need for second valve. All studies have shown that balloon expandable, you need less chance for second valve compared to the self-expanding valve as shown here. And knowing that with the newer design here, the moderate to severe AR was identical between two groups, except that the pacemaker rate continued to increase with the self-expanding valve. Then the choice trial, I would say the first of the randomized trial, which was published about 4 years ago in JAMA, again from Germany, showing the randomization of 240 plus patient to TAVR with the balloon expandable, TAVR with the self-expanding valve, and the 30-day outcome was published in JAMA. And overall, the procedural or device success, and device success they define as successful valve placement with good vascular access and one valve in correct position and less than moderate to severe AI. And you can see here the primary endpoint for the device success was significantly higher with the balloon expandable Sapien valve compared to the core valve. So the big difference, 95.9 versus 77.5. Also, in terms of moderate to severe prostatic regurgitation, you can see 4 versus 18.3. These are the earlier generation core valve. I mean, very, very important. Then the key is that needing additional valve, 0.8% in the balloon expandable and 5.8 in the core valve. So clearly there was a difference, and acute success of the 30-day favored the balloon expandable valve. And these are the individual endpoints which showed basically clearly the less pacemaker, vascular complications and bleeding were identical, stroke was identical, death was identical, but implantation of 2 valve and moderate AI really was higher in the core valve group compared to the self-expanding versus balloon expandable. Then they published the same group for 1 year data of the same choice trial, and it's basically that now those patients of the 121 originally, then patient died about 5 patients died at 30 days, then another 15 died at 1 year. So 100 patients were compared at 1 year for the subsequent data and showed basically at 1 year, again identical, while there was an initial advantage of the balloon expandable, as you saw, that clearly that now you see only major difference in my opinion remains in the pacemaker, that the higher pacemaker rate with the self-expanding versus balloon expandable, but others are identical, maybe some softer endpoint, repeat hospitalization lower in the balloon expandable versus the self-expanding, but the death and stroke were identical. So this actually puts it together, so of the 2 choices. So then we actually have a major trial presented, has not been published yet, presented in TCT last month with a 2x2 randomized trial of 2 concepts, self-expandable, expanding versus balloon expandable, or general versus local anesthesia in these patients. And you can see the 2 concepts were that which valve is better, the direct comparison of the Sapien valve, Sapien-3 versus Evolute, and second was the anesthesia strategy, that using the general anesthesia versus local anesthesia with conscious sedation. And there was a plus and minus, no randomized trial until this time, which was shown. So this is factor 1-to-1, I mean 2x2 randomization, which we call both of the valves which were evaluated along with 2 anesthesia strategy. And basically these were the hypotheses that both valves will be equivalent. And second is the local anesthesia with conscious sedation is equivalent to general anesthesia. So what did we see? So 2 things, valve strategy first. So valve strategy, about 200 plus patients were evaluated for the 30-day short-term outcome. And you can see here, there are various baseline comparison, but they're all identical. But more importantly, basically, if you can see the valve sizes, and so, but inherent differences in few things. One is the pre-dilatation was identical, but post-dilatation, as you can see here, was higher with the Evolute valve compared to the Sapien valve. And of course, the contrast agent also lower with the Sapien compared to the Evolute R. So the valve strategy, which is the all-cause mortality, stroke, moderate to severe AI, and permanent pacemaker at 30 days were identical, 27.2 in the Evolute, 26.1 in the Sapien valve. These are the individual endpoint of mortality, stroke, moderate to severe valve regurgitation and pacemaker. You can see here that stroke somehow, this is the first report which I saw, Sapien-3 having a little higher stroke rate than Evolute. You want to comment on how, because most of the trials showed actually Sapien group have slightly lower stroke rate, if not, I mean, not significantly lower, but numerically lower. And this is the trial which showed the Sapien-3 having a 4.7% stroke rate at 30 days compared to Evolute, which was 0.5, which is not only non-inferior, it was actually superior in favor of the Evolute.
Yeah, I think we have to look at the data carefully and see how much, which of these patients get pre-balloon dilatation, post-dilatation. I think that could matter. I think certainly I agree with you. This is the first study that showed that, because it's, compared to the partner 2, S3I, it was certainly much lower. So I think really depends on the practice. We don't know if the cerebral embolic protection was used here. Certainly this is not what we do in contemporary practice anymore, at least in the United States in our program.
Well, on the other hand, we can see that also the pacemaker was quite high.
Yes.
Or the higher than
Both
expected.
valves.
So one wonders if somehow the balloon expandable valves were super expanded or oversized or something like that. So maybe they were dealing with very huge annuli or there might be some kind of a situation like that, because a 90% new pacemaker rate is also a little bit higher than I would have expected.
Yeah. Our center's pacemaker is less than 10%, about 5 to 6% overall.
Yeah. So clearly, the sentinel device was not used in this, and the pre-dilatation was identical in both, but post-dilatation was much higher in the Evolute compared to the Sapien. But pre-dilatation was identical, about 26%. Post was different. More people require dilatation to decrease the regurgitation. And more important, look at the now. Moderate to severe valve regurgitation, which used to be different in favor of the balloon expandable, is no longer there. Because the way this Evolute R Pro or so clearly they were both used, Evolute R as well as Evolute Pro, that really the regurgitation is no longer a difference, but the pacemaker is still numerically lower with the Sapien valve, but not a significant number. Now then, these are the individual endpoints which are shown here in terms of efficacy, device success, and so on and so forth. Not much different. Then second was the anesthesia strategy, that whether you use a general anesthesia versus the local anesthesia, and basically showed that medication use, you can see the general anesthesia in the blue, the medication use with the catecholamine requiring medications was much higher in the general anesthesia group compared to local anesthesia. Of course, there were majority of them, just like the case which we did today, were done with propofol, but many other agents and fentanyl, but many other agent difference was seen in the general anesthesia group compared to local. What does it mean? Overall, outcome-wise, both were identical. 27% in the local, 25.5% in general anesthesia, and they define their safety point as mortality, stroke, MI, infection requiring antibiotic treatment, and acute kidney injury at 30 days. Because infection-wise, largely because of the aspiration and acute kidney injury, that was the feeling that maybe general anesthesia caused more hypotension. And you can see here, identical individual endpoints of the 5 component which made the primary endpoint. So no difference except little high catecholamine inducing drug in the general anesthesia group. So these are shown basically here. And once again to emphasize, so what I just want to put it back. So what did we learn? We learned that overall, most of the time you can use any of the valve suitable for either valve, but there is no prospect to trial to say that in this situation you do better versus other. But this is, I have put it together, that where would you use Sapien-3 better versus Evolute? The Sapien-3, we know that for transapical, there is not a, cannot be, you don't have any the cases of using the core valve. Then very large and very small annulus less than 19. Then you use a Sapien. Horizontal aorta, more than 60 degrees, the Sapien will be better. Then concerned about permanent pacemaker, Sapien will be better. Patient with extensive CAD or prior PCI, as our paper showed, that is tough cannulation. If patient has a core valve, so patient who has CAD, we try to favor more a Sapien valve, and then of course the lower coronary height or a small sinus of Valsalva, Sapien. Anu, you want to comment on the CAD and the Sapien versus core valve at Mount Sinai?
I think like we have mentioned, if patient has had, especially if the intermediate risk and presence of CAD and PCI, which probably we are talking about 20% of the cases that we are doing, that if possible, we would like to do Sapien just because of the re-access, which we have shown earlier part of this year, that engagement is much better if you are doing Sapien rather than the Evolute.
Okay, now Evolute R will be dense subannular calcium, clearly. There, high pressure dilatation can give a balloon expandable, can give rise to more annular rupture and perforations, intolerant to rapid pacing, because clearly Sapien will require rapid pacing. Ejection fraction is 20%. You want to go in and come out without pacing, deploy the valve, evolute R is your friend. TAVR in surgical valve in valve because of supraannular location. Then hypertrophy, the iliofemoral, less than 5 millimeter, knowing that the 14 French can be used for the evolute. Not the Evolute Pro, but Evolute R, 14 French. So the arteries are really 5 millimeter. I would say Evolute will be preferred. Then hypertrophic septum. Clearly that you are worried about the valve just pushing out. And the subclavian approach, although we had done 2 cases, even using the Sapien, but by and large, when we did a subclavian approach, Evolute R is your friend. So Gilbert, anything else you want to add or comment on this, the valve choice between two, any of special scenario? Any other scenario?
No, I think this is a great summary to look at that. Obviously, Sapien-3 is now approved for transcatheter mitral valve in valve replacement as well. We've done also in mitral tricuspid or valve in MAC, so it's certainly a more versatile
bicuspid and when there is low, very less calcium, I think the Evolute R probably
That's
is a
right.
better
So
choice.
it comes down to also the degree of calcification, because you always, the Sapien-3, you're concerned about potential migration if you don't have sufficient calcium to anchor the valve.
Okay, so good. So we'll let some, then there is another trial, only one more trial of the comparative is the Reprise 3, where they compare the Lotus valve with our core valve. And basically the data of the Reprise 3 randomized trial shown of the 900 plus patient, identical outcome at 1 year, except there was a lower stroke rate. As you can see, lower stroke rate with the Lotus valve compared to the core valve. And of course, the lower regurgitation. The significant regurgitation was less, and the rest of the points basically are shown here in this study. So clearly this device hopefully soon will come. The overall, the moderate paravalvular leak, which is very rare with the Lotus compared to core valve, and shown here. So now, if I sum it up, the 2 randomized clinical trial and 2 registries of balloon expandable versus self-expanding TAVR valves have showed similar outcomes in majority of severe AS patients, with some pro and con of each valve in a specific clinical and anatomic scenario, which I put it together in that comparative slide. The smaller vascular access, in my opinion, will favor Sapien, the self-expanding Evolute, while presence of extensive CAD will favor the balloon expandable Sapien 3 valve. Then future efforts need to focus on reducing the need for permanent pacemaker, prosthetic regurgitation, and leaflet deterioration after TAVR, especially when this technology will be applied to a younger and low-risk patient. These are essential to really establish TAVR as the destination therapy in younger patients. Knowing the data of both the trials will be presented in ACC mid-March next year. So just to quickly go with our 5 questions as a part of the will be a CME activity. Following are the randomized trials or registry data comparing Sapien versus self-expanding versus balloon expandable TAVR, except Notion, Choice, SALT-AVI, and Pragmatic Plus, right? Clear that Notion is the trial of low risk comparing surgery versus TAVR. Second, following are the true statement regarding the 30-day results of the Choice trial comparing balloon expandable versus self-expanding TAVR, while except stroke incidence is similar between 2 groups. Mortality is higher in the self-expanding group versus balloon expandable. Permanent pacemaker is higher in self-expanding versus balloon expandable, and the device success is similar between 2 groups. So all 3 points were at 30 days were not different. As you can see, the difference was only in the device success, which was much higher with the balloon expandable compared to the self-expanding. Now this same 1-year data where stroke incidence is similar between 2 groups, mortality is similar between 2 groups, vascular complications higher in the self-expanding versus balloon expandable group, and bleeding complication is similar between 2 groups. Clearly, as you saw that subsequently they were identical. So see that not higher vascular complication, they were identical in both the groups at 1-year follow-up. The number 4, following are the 2 regarding the results of SALT-AVI trial comparing balloon expandable versus self-expanding TAVR valve, except stroke incidence is similar between 2 groups, Mortality is similar, pacemaker is similar, and moderate to severe AI is similar between two groups. So the question basically was that what is except in two showed the difference, and you saw that the stroke, 30-day stroke in the salt TAVI was higher with the balloon expandable versus self-expanding group. Why it is, we still need to understand. One of the important things which have been shown in the past is AFib. Once you get AFib, you have a higher stroke rate. So they have not really defined those that really develop AFib, persistent, whether got anticoagulation, we need to see. Once the paper comes out in publication. And the last question, following are the true regarding the results of salt TAVI trial comparing local anesthesia versus general anesthesia during TAVR procedure, except stroke incidence is similar between two, mortality is similar between two, AKI is similar between two, and lastly, catecholamine med use is similar in general versus local anesthesia group, as I can show that the answer D. And with that note, our didactic discussion is done. If we can bring the camera to show it to the femorals.
Good. And just show the angio if you want to put that up as well. We just take, I just wanted to show that.
Exactly.
So just to show the angio, this is the tortuosity we're dealing with here, and we still go up and over, and the up and over is harder in that when it looks like this, and it's very tortuous. But the flip side is that if you don't go up and over and you have a complication, it's even harder to get up and over at the end, trying to deal with a complication when you can't get wire purchased. So we successfully navigated up and over before this case, put an 018 wire, and I'll just show you the final pictures here. So the steps of the pre-close is we first rail up on our 018 wire.
Yeah, let's just go step by step with the angiograms there, Jason. Just so we can.
Let me just get
many people not very familiar with the up and over situation, and I will make a comment regarding an alternative protection technique as well.
Good, guys. Could you just advance out there, Mary Chu? Yeah, thanks, Ramon.
All right. Anyhow,
take us back to the first DSA.
But you can see first of all the tortuosity. Let the doctor describe the tortuosity.
So the tortuosity was worse on the left, and you can see there's an almost 180-degree bend going backwards. But we used the left side as the as the minor axis side, the major. Just skip forward to the first DSA. Yeah, right at the end, the closure. Go right forward. Or can I do it here? And I'll just talk as I go. Leave it to me. So up and over, this is us crossing. So this is the beginning of the procedure. And just to show you what we did is we have on the left side is the minor access. We changed that out for an up and over sheath on our 018 wire. So you'll see here, this is our first picture. We have a long sheath now poised right at the top of the aortoiliac bifurcation. In our first shot, we've retracted the large 16 French sheath back into the external iliac. We then rail this long exchange sheath up and over, deploy the per-close sutures. We still have both an antegrade and a retrograde wire here, the 018 going right down to the knee on the right side. And you can see there going off to the left of the picture, significant bleeding coming out of the arteriotomy side. And again, this is one of the reasons we go up and over is to deal with this. So we administered protamine, reversed the heparin, we balloon dilated this as an 8040 balloon to 6 atmospheres. We actually did 2 inflations, and you can see here the final shots. Now, very satisfactory with no bleeding, easily dealt with by reversing the protamine and about a 2-3 minute inflation. Once the protamine's reversed, we still can stay out for about a minute or so. So very satisfactory.
No pinch of the artery.
No pinch. Looks great.
Okay. Excellent
well,
presentation.
definitely great, and you can see in the final picture how actually the up and over was used here for adjunct balloon dilation from the inside. Actually, I shouldn't say dilation, it's balloon sealing from the inside, and then helped the hemostasis. But clearly, one have to also mention that the many people don't understand how the wire how the guide actually the contralateral sheath crosses into the other side so easily over the 018 wire. Let's remember that the big sheath, the valve sheath, is essentially anchoring that wire somewhere in the common femoral area as well. So the wire is stuck essentially. That's why it's much easier to take that sheath across than would otherwise. Let me remind everybody also that in case you have an access in the radial, you can use an ultra long multi-purpose catheter to take selective iliac picture from the arm in a case that you absolutely cannot go contralateral, and potentially you can even thread a wire from there and use that scenario in order to facilitate. It's suboptimal, but if you cannot go up and over from the iliac, maybe you can demonstrate that in another case. I think we're all done. I see the entire lab ready, anxious to end the case, and I think our viewers as well had some great questions that I brought up with you during the case. We're all set about that, and I think we're ready to conclude. Congratulations yet again.
And this is our team for today.
Very good. So we thank the heart team members on the cath lab and the cath lab team entirely, the imaging and the nurse anesthesia as well, everyone, and the technicians. And I thank, of course, the viewers for joining again for this very exciting and great case. Obviously, the recording is not ready right now, but it will be uploaded and archived at this website a few hours from now. And I encourage everyone to review it along with the previous other webcasts we've done in structural heart life cases, as well as other cases from this website. As you may remember, the structural heart life cases are conducted every other month. So this is the last one for the for this calendar year. Happy New Year to everyone. Comes up in 7 weeks or so, and we're going to see you in 2019, Tuesday the 8th. Same time as you viewed us today, 9 a.m. Eastern Standard Time, or any relevant time you are around the world. Thank you again.